Welcome to this video on the Glasgow Coma Scale, a crucial tool in assessing a patient's level of consciousness. Before the Glasgow Coma Scale, subjective and vague terms like semi-conscious, disoriented, and stuporous were used, leading to inconsistencies. The GCS provides an objective standard. The GCS was developed to objectively classify and assess the level of consciousness. It specifically checks for two main things: arousability and awareness. When addressing a trauma or unresponsive patient, the preliminary examination follows the ABCDE protocol. D stands for disability, which involves assessing neurological status. We use the GCS to check for disability, but it is not a full neurological examination. It is vital for initial assessment, communication, monitoring changes, and holds prognostic value in head injury. The Glasgow Coma Scale is based on three components: eye-opening, verbal response, and motor response. These are often abbreviated as E, V, and M. Each component has a maximum score. Eye-opening is 4, verbal response is 5, and motor response is 6. The minimum score for any component is 1. The total score ranges from 3 to 15. For eye-opening, a score of 4 is spontaneous opening, 3 is opening to speech, 2 is opening to pain, and 1 is no opening to none of the stimuli. To assess verbal response, interact with the patient. A score of 5 means oriented, 4 is confused, 3 is inappropriate words, 2 is incomprehensible sounds, and 1 is none. Let's consider some examples for verbal responses. Groaning loudly to pain is V2. Shouting random words is V3. Saying "My name is Sharma, I am at home" while disoriented is V4. Motor response is scored from 1 to 6. 6 is obeying commands, 5 is localizing pain, 4 is withdrawing from pain, 3 is abnormal flexion, 2 is extension, and 1 is no response. When testing motor response, always begin with a peripheral painful stimulus, like nail bed pressure. If there's no response or only withdrawal, move to a central stimulus to check for localization or abnormal posturing. Pain stimuli can be applied using fingertip pressure, trapezius squeeze, or pressure on the supraorbital notch. The 6 possible motor responses are obeying commands, localizes pain, withdrawal, abnormal flexion, abnormal extension, and none. GCS scores categorize injury severity. 13 to 15 is mild, 9 to 12 is moderate. A score below 8 indicates the need for intubation, and below 5 is considered very serious. The 4-step approach to GCS is: check the patient, observe the response, stimulate if needed, and rate the best response observed on both sides. Consider Mr. Arpit with Guillain-Barré syndrome. Open eyes give E4. Answering "How are you" gives V5. Obeying a command to stick out his tongue, despite paralysis, gives M6. Total GCS is 15. Common pitfalls include not assessing the best response, using incorrect pain stimuli, and issues like language barriers, hearing impairment, sedation, facial trauma, or aphasia. Remember, the GCS is dynamic. The trend is key. Always document the score in full details and consider the cause. It is part of the ABCDE assessment and has prognostic value in head injury. Thank you for watching this video.